All right, so numbers are starting to build. So look, I'll get started with the introductory things so that as the numbers come, we'll just welcome them. So to everyone here, welcome, and really look forward to this session today. Today's session is about impactful projects, and we're going to be announcing our HTSA Research Impact Awards and having some project showcases. I'm going to talk a little bit at the start, which will really just introduce some of the work that we've been doing around impact. But before that, I'd like to just acknowledge that we're meeting on Kaurna land, or I certainly am meeting on Kaurna land, and pay my respects to Kaurna elders past, present and future, and acknowledge the importance of the work that's been done with Aboriginal leadership across South Australia to actually make a difference in the health of Aboriginal and Torres Strait Islander people. So what I'd like to do now is just talk a little bit about the series. What this is about is HTSA putting a spotlight on areas of interest and importance for South Australia. Prior to Christmas, we focused on the implementation science area, and we had a fabulous series of 4 sessions around implementation science, looking at it from all different angles. And those presentations are available to anyone who might be interested to review those. So please, I encourage you to look at them. We had some fabulous speakers. And now this Spotlight series, we've had another excellent range of speakers who've been able to really share some of their insights on research impact. We know it's the flavour of not just the month or the year, but probably the next 5 years, about really orienting research around impact and the effort that we all need to go to ensure that that is the focus of what we're doing is really relevant. And I think will become more and more relevant to funders as things hot up in this space. So HTSA really, acknowledging that we need to be leaders in this space, wanted to orient a session around this. And we used our Spotlight series to do that. We had in our first session, hopefully many of you were attending, we actually talked about research impact and did an introductory, and Akusha Lindale, one of our staff members, a fabulous, who's actually stepping in for me while I'm going on leave as the Deputy CEO, kicked that off. And then we had Tamika Hayden from the Research Impact Academy, who spoke about research impact. We then had Tobias Skoll, I think, of Shop, not very good with that name, from Grow Impact, who was talking a lot about the impact measures and how they do it, and also Nhmrc Dowd. So again, a really interesting session. And then earlier this week, we had Professor Julian Grant, who's part of the Nhmrc Research Impact Committee, speaking about research impact from the Nhmrc's perspective. So to date, we've had these 3 fabulous sessions. These will all be available for you to use however you would like to, and to gain those insights. So now I'd just like to share my screen and then introduce a couple of other things about what today's session is about. So let's click on that share screen and hope that it all works. There we go. Oops, no, it's not. It's always the way, isn't it? Stop sharing. Let me just go back. Sorry, everyone. Thought we had this all set up. Here we go. So let's just go back to the... Sorry, come on. There we go. Okay, so... As many of you are well aware, HTSA, there we go. HTSA is a partnership between 11 active partners, and we're really pleased to be representing them all here today. What I want to introduce today is we've got 2 terrific speakers who I'm going to introduce a bit later as well, is Professor Maria Makrides and also Professor Susan Hillier, who are going to speak to us today on the projects that they've been involved in and the impact that they've been able to have. So HTSA is really about accelerating the translation of findings into healthcare practice and policy, and to increase whole of system research translation capacity to improve the health of all South Australians. Hence, these seminar series and the things we're focusing on are critically important in this whole area of increasing whole of system research translation capacity. We work with a whole range of key stakeholders across education, training, health services, research, primary care, Aboriginal care. We have a lot of consumer and community involvement, and we understand the importance of influencing policy along with all of these other bits and pieces. So it's a busy agenda that we're running, but we really work as an independent catalyst and broker to mobilise collaborations and to get people to focus on those major health system challenges. We've just recently, or middle of last year, finished our new strategy, and that is about bringing the right people together, about building the right environment, about getting the right projects done, and celebrating and showcasing impact. And again, this series is about that, about our ability to showcase what's going on, but also about getting the right projects done. So we're very clear that achieving impact is about a mindset. It's about starting, it's about doing activities, having outputs, outcomes, impact, and then figuring out how to do it in a sustained and scaled way. Ultimately, you've got to have a problem that you're trying to address. It has to be a real problem. It has to be a problem that a whole lot of people are going to buy into. Otherwise, you know, you might find that you're barking up a tree that is the wrong tree. It's about thinking who is the next users and who are the end users of the research you're involved in, and working out how they can be incorporated from along each of these steps. The whole process of research translation starts right at the start and not at the end. It starts when you're actually conceptualizing the project and actually figuring out what is the problem, what is the need, and having the right people around on that whole journey. So what we've been able to do is develop this Spotlight series to really highlight the things of interest. We've got another one that we're planning, and we're talking about the Medical Research Future Fund in June. And so we'd really encourage you to keep a lookout for when that one comes along. We actually partnered with Sarlan and Flinders University last week, and Flinders Foundation were very supportive as well, to run a statewide Medical Research Future Fund Summit. And there was some fabulous presentations from the MRFF, along with a number of leading presenters, leading researchers and clinicians across South Australia that were able to provide insights on what they are already doing in the Medical Research Future Fund. So we'd like to highlight those stories that we heard last week, but also bring along other information for people around the state so we can have more success in the MRFF area. We're also looking at, in October, having a Spotlight series on consumer engagement, and I've already mentioned the previous Spotlight series. So now I move on to something. I just want to give you a couple of moments telling you the story about these Nhmrc centres. So we are an accredited Nhmrc translation centre. There are 10 of them across Australia. We come together through a thing called ARA, the Australian Health Research Alliance. We were first accredited in 2014 and really were established in 2015. And we had to just go through a process of re-accreditation. So luckily on January the 20th, we were able to submit our re-accreditation application. Many of you around this call might have been involved in this process. And if you were, I want to just say thank you. But what we had to do was to describe our achievements since 2015 and also our plans for the next 5 years. But it was a great opportunity to showcase the work that HTSA connected projects were doing. And what we did was reach out to our projects that are our flagship projects, and also our projects that were funded under the Rapid Applied Research Translation scheme. And we had 3 rounds of that scheme to really ask them, what did you do? What was the impact? Now, some of those have a level of maturity that was actually in advance of others, and so they were able to have more impact than others. But the message was the so what factor. What difference are you actually making out there? Yes, your research is incredibly important and doing it the way you need to do it with the right methods, etc. But what difference is it making? So we sent out a survey, as I said, to all those people, and thank you for anyone who's on this call that responded. It was fairly detailed because we had a number of metrics which the Nhmrc were asking us to report on, and the responses were absolutely vital for our application. The application had 5 sections, and the first section was actually on research impact, and we were able to showcase 5 case studies in that application. We actually did highlighted the work that the South Australian Aboriginal Chronic Disease Consortium had been working on. They have a lot of outcomes that were coming through that work. Some of them was early, but a lot of them that actually had some significant both system and practice level outcomes. We also showcased a project that has had some good support from HTSA. That's a Flinders-based project, and that's AI Squared, and that's a digital clinical support program for mental health clients. And that was a really interesting project. And again, it was relatively early days, but no doubt a rising star application for the future, we believe. We also did a section in that impact section around research ethics and governance, and the process that HTSA worked with SA Health to really supercharge their research ethics and governance. So we're not going to claim that it's perfect now, but definitely we moved it along a significant way in that 12 months we had a spotlight on that work. So that was some of the projects we highlighted in the impact section. We also had to do a section on excellence. And the reason I want to tell you this story is that we didn't want to report just on research excellence the way that traditionally with the traditional metrics. We actually wanted to tell people that the way we interpret research excellence, yes, we acknowledge we need publications, we need grants, we need that stuff, absolutely no doubt. But we also wanted to talk about the way we evaluate research excellence, that you've got consumer engagement involved from the start, that you are focused around impact. And we had a number of other criteria that we used to really, and we put forward, probably a little cheekily, to the Nhmrc, we put forward the idea that this is how we really think things should be excellent. And what we are now doing is developing a short course that's around research translation essentials. And some of the learnings we had from pulling this application together and doing these webinar series and all the other capacity building that we've been working on are things that are going to inform that research translation essentials course. So hopefully that'll be available later in the year, and we can actually get more people really understanding and being able to discuss and debate the things that matter if we're going to translate research into practice and policy. So look, the reaccreditation application was an absolute huge piece of work. I want to thank everyone and anybody who was possibly involved in that process. But what we did promise for people who were actually responding to that survey is that we would put out research. Just make one more acknowledgement of a couple of other projects that were very to our application and also had a lot of strong data from when we did the survey. The Registry of Senior Australians, ROSA, had made an astounding contribution to informing decision-making and reform across Australia, and we'd like to acknowledge the great work there. I'd like to acknowledge the work that the Action Kidney Care project called Action, that Kim O'Donnell and Janet Kelly are leading. They've had some amazing outcomes as well. So in terms of rising stars, look, I've talked about a number of projects. They're all rising stars, and just keep working on the so what, keep working on getting stuff embedded in practice so it can be ongoing and make a difference to people for as long as need be. There was one other project that is no longer a flagship program for HTSA, and that's called the No Australian Dying of Bowel Cancer Project. This was actually a very active project for 3 years and informed a lot of state government decision-making and work around colonoscopies and how that happens. So really that project is no longer in position because it actually influenced significant investment in the area of colonoscopy in the government. So it made a decision that it was able to step back and change its map. So I suppose I wanted to give you that sprinkling of information because each one of those projects and many others are all working in a way that's going to really be an impact award in itself in the future. And we look forward to continuing to recognise the great work that is happening across South Australia. And what we did also hear from the Medical Research Future Fund, and straight from the mouth of Marsha Somi, the lead of that program, is that they want your stories. So if you have stories that are about winners for the MRFF, you know, things that have actually happened as a result of their investment, please send them through, CC us in, but send them straight to Marsha and the team in the MRFF in Canberra, because they want stories and they don't get them. She told me they actually troll through their records trying to find stories. So I just encourage you all, if you've got impact stories, then you've got some MRFF money, get it through to them because they need it. So with that, I probably should move on. I've probably talked enough. I'd like to introduce the winner of our Research Impact Award is Professor Maria Makrides, and the work that with her team that she's been doing in reducing the risk of preterm birth. And it's a fabulous project, and we're really pleased that we'll be hearing from Maria in a moment. But just before I do that, I'm just going to go on to one more slide, Maria, and then it's back to you. But congratulations on being the winner of this award for 2022. We really appreciate the working relationship we have with your team. We know that we're able to, some of the things we've worked with you on have contributed to, I guess, making your project better, but certainly being able to showcase the great work from your team is fabulous. The other one I'd like to introduce now and just acknowledge is the Research Impact Award runner-up. And this is the Stroke Datalink Project team. And Professor Susan Hillier from UniSA, who's the Dean of Research in Allied Health and Human Performance, is going to tell us that story in a moment as well. So both of these projects have been, you know, great contributors, often working in really tough environment, you know, cobbling together money from here, there and everywhere. But just to acknowledge, we've got some really good stories to tell. So now I'd like to actually formally ask Maria to present to us. I'm going to stop sharing and then we'll move on to Susan. Now, if you do have questions during the course of the presentations, please put them in the chat. Don't hesitate to have questions. We will have a bit of time at the end of each session, and we'll be looking forward to answering your questions. And also looking forward to just having a discussion at the end if we've got time. So Maria, with no further ado, I think I'll hand over to you and look forward to hearing about your project.
Thank you very much, Wendy, and thanks to HTSA for the recognition. It's fantastic, and we welcome it, and it has been a wonderful journey, but still a journey to go, and that's what some of the information I'd like to share with you all today. As with many large projects with an implementation scope, there's many people involved, and I'd just like to highlight a few people who are currently part of the implementation team for our program to reduce prematurity rates in South Australia, and particularly pay tribute to the current workers in terms of Karen Best, Philippa Middleton, Vanessa Anfiteatro, Celine Northcote, who is actually a student and joined the team and is about to do great work in some consumer engagement. work. Bob Gibson, Lisa Yelland and the team at SA Pathology, particularly ably led and involved from Penny Coates and her team, and the people in the newborn screening service and the antenatal serum screening service, and particularly Kwa Lam. So thank you all very much. And just to start off that, you know, this has been a long journey, and our work in the area of omega-3 fatty acids and pregnancy outcomes has probably been a 25-year journey. A significant turning point for us in terms of thinking about impact and implementation has been the recognition of the work over a long period of time. And at the end of 2020, the Australian Pregnancy Care Guidelines, having for the first time an Nhmrc endorsed recommendation to advise supplementation of omega-3 fatty acids for women who are low to reduce their risk of prematurity. Wendy, you mentioned earlier some of the rapid translation funding, and I guess what was important for us and came at a critical time was the rapid translation funding in 2016, which was absolutely vital for us to complete the Cochrane review for omega-3 supplementation and pregnancy outcomes, and to also complete the fatty acid analyses from the largest trial to delineate the effects of omega-3 supplementation based on omega-3 fatty acid status, and that'll sort of become obvious. So Philippa Middleton led the Cochrane review. Karen Best and Bob Gibson and Lisa Yelland were instrumental in the analysis of the ORIC trial as the largest trial. So why is preterm birth such an important issue? Every year, 15 million babies around the world are born preterm, which is basically birth less than 37 weeks. That accounts for about 85% of all perinatal complications, and it's the leading cause of death for children under 5 years of age. In most cases, for singleton preterm births, up until now, they've occurred with no known real biological reasons. About 20% of these preterm births are ones that happen early, before 34 weeks, and these are the ones that are associated with the biggest morbidity and mortality. In Australia, we have 26,000 babies born preterm each year with an annual cost of $1.4 billion. So it's a big problem that's worthy of investment in prevention strategies. So what was so important about the Cochrane review that was actually released on World Prematurity Day in 2018 was that for the first time we had conclusive evidence of a way of a preventative strategy for preterm birth. The review included 70 randomised trials with almost 20,000 women, and the results indicated that we could reduce early preterm birth by 42% and preterm birth by 11% with omega-3 supplementation. We were worried about issues to do with quality, as one always is, but the sensitivity analysis showed that the high quality, if you only included the high quality trials, the effects were entirely consistent. So we were pretty sure that we had conclusive evidence to be able to move forward here. However, there was a big puzzle for us to solve because these results seemed at odds with the largest trial. And we all like to see when we're looking at evidence base and that the largest trial and the Cochrane review or the systematic review actually are aligned and show similar outcomes. The largest trial being our ORIC study, which was conducted in Australia across 6 centres, was a blinded randomised trial with over 5,000 women. This trial was specifically designed to be one to deal with contemporary practice and to test the notion that if we actually supplemented everybody, and assessing that broad-based, population-based strategy of complete or universal supplementation. So we included everybody. There was no specific exclusions. There were singleton pregnancies, multiple pregnancies. If women were already taking low-dose supplements at the beginning, they were still able to join the trial and be randomised to one of the products. So we were really focused on this contemporary practice for both health professionals and women, and this was a big difference to the past trials because most of them were done before the current contemporary practice of people taking prenatal supplements, many of which have low-dose omega-3 fatty acids in them. Because of that, we were very careful to make sure that we understood the fatty acid status of the women as they were coming into the pregnancy. We were very pleased that, led by Bob Gibson, we were able to take these blood spots on specially treated filter paper that stabilised the double bonds in all the fatty acids, so we could actually have an easy way of measuring status. This actually became really important for us to understand the results because when we looked at the intention to treat analysis of ORIP, supplementation resulted in no net benefit in terms of reducing prematurity. So we really needed to dig a little deeper. And in our secondary analysis, we did find that it was the omega-3 status in early pregnancy that was the key to predicting the response to supplementation in terms of lowering the risk of early preterm birth. So if we just focus on the graph here, this is the total omega-3 status of the women entering pregnancy. And on the y-axis, you see the relative risk of early preterm birth. So if women had a low status in early pregnancy, their risk of early preterm birth was significantly reduced. There was this sort of null effect in the middle, but if they had a replete or higher status and they were supplemented with about 1 gram of omega-3 fatty acids per day, their risk of early preterm birth was already low, but it actually increased with supplementation. We looked at different ways of assessing status, and it was all by adding up all the total omega-3s that we actually were able to identify the most women with low status and the greatest reduction. So if we just looked at only 2 of the omega-3 fatty acids, EPA plus DHA, again, the same sort of curve, but we were identifying fewer women with a lower reduction in early preterm birth. And if we only looked at 1 of the key omega-3 fatty acids, we were identifying the fewest women and a reduction. So it really did seem that total omega-3 status was the best biomarker to predict response to supplementation because it identified the most women with lowest status and the greatest risk of reduction. The women with replete status at that higher end were also the ones that were more likely to be taking supplements, prenatal supplements with low-dose omega-3 fatty acids in them anyway. So this was actually a really important finding about showing how contemporary practice actually does move on a bit. And it's quite important to think about in terms of guidelines. And I guess this is where the Australian Pregnancy Care Guidelines, independent of the research team involved in the trials, but linked through Philippa Middleton as an implementation scientist, it did issue this evidence-based guidance about advising supplementation for women with low status. However, that was fantastic. We were overly pleased with the recognition of the work, but 3 important gaps if you think about how do you get the guideline into practice. If we want to routinely identify who's low in omega-3 fatty acids, the only way to reliably do that at an individual level rather than a population level is to individually screen women through a blood test. There's obviously a gap in the knowledge for health professionals and women about the screening and then what to do with the screening result, the appropriate action to take. And there's also a gap in the availability of appropriate supplements, because many of the supplements are prenatal multivitamin and mineral supplements with lots of things in them and very low doses of omega-3 fatty acids. So to try and address some of these gaps, we set up a partnership with SA Pathology. And after many discussions with our colleagues at SA Pathology, it became obvious that the easiest program to think about implementation of a screen and treat type program was through the South Australian Maternal Serum Screening Service, which at the moment covers about 80 to 85% of women in South Australia before 16 weeks of pregnancy. By partnering with SA Pathology, it meant that no additional blood test would be needed, that we could use an aliquot of serum from the serum screening service, and that as part of our implementation study and evaluation, we could offer this at no cost to the women or the health service. And this was actually an important thing, and the oversight for the testing was organised in such a way that SA Pathology with the SAMRI team oversees the testing so that we can meet all the appropriate accreditation standards of a pathology service for offering the test, given that the doctor, the GP with the woman would tick the screening box, the blood would be collected through usual SA Pathology services, be transferred to the SAMRI lab for analysis. We would report the results to SA Pathology, which would be issued through OASIS and the usual channels for the requesting doctor. The big hitch that you noticed that I made a special mention of our dried blood spots and how proud we were of them, because we thought that was a really clever way of being able to collect blood remotely. It would be dried, it would be easy and cheap. Well, SA Pathology didn't want that. They wanted to fit in with their current workflow and their current systems that they had, and there was actually no available workflow in the pathology service for dealing with dried blood spots other than the newborn screening. So we needed to go back to the drawing board and do a whole lot of validation to make sure that the cutoffs that we had for the dried blood spots could actually convert to serum. And this is just a little figure showing that in actual fact we could do this, and that we had to set up a whole lot of equations to work out what the new cutoffs would be in the serum. We fortunately had another 450 or so samples in the freezer from women in the ORIP study, so we were able to test these validation equations for whole blood to plasma and serum, and make sure that there was strong agreement in the actual pregnant women that we actually used to derive the original curves. Most importantly, there was no misclassification of women between low and replete status in the two fractions. Now, these two papers were actually quite important, but they're what I would call the boring, not sexy work that's needed in terms of implementation to make sure that you can put your hand on your heart and confidently say, this is what's needed. So we were able to go ahead with the implementation program and we have, you know, depending on whether the omega-3 status is measured in the serum, you see the cutoffs here are a little different to the ones that from the whole dried blood, but the recommendations are there in line with the pregnancy care guidelines that for women who are low, they need to be taking the suggested dose of almost 1 gram a day to reduce their risk of early preterm birth. The moderate status women, really no particular action is required, and the replete women, they don't really need to do anything else because they're already at low risk of early preterm birth. And if they want to choose to continue to take their prenatal supplement, that's okay as long as it remains at that low dose. The engagement with our health professionals and consumer group were absolutely vital to make sure we had all that advice right and that it was easily understandable and translatable. This is Rhiannon Smith, who's the key GP on our steering committee, and who's been absolutely wonderful in helping us in terms of making sure that community interface is absolutely right. The consumers obviously wanted flexible choice, that if they're taking other supplements or vegetarian options, and the delivery of information had to be immediate. So the printout that comes from SA pathology with the result has an action point about what the doctor needs to tell the woman immediately, and the pamphlets are available for extra backup information. So this all came together over about a 12 to 18 month period. We launched the program in late 2021 with the release of the new SA Pathology SAMSAS forms. When these forms were released, an email went out to all providers of SA Pathology or who order tests from Tom Dodd to introduce the test. And in parallel, we had a lot of education services, sessions and relevant conferences to GPs, obstetricians and midwives. To the end of January this year, we've done over 3,000 omega-3 screening tests. We're now consistently at over 100 a week. We estimate to get maximal coverage and be able to cover all eligible women in South Australia, we need to get to 300 a week, where we're currently at about 35%, so we've still got some way to go. We have found, as with SAMSAS, that 92% of the tests, well, more than 75% of the tests are ordered through GPs. So the work in the community is absolutely vital. The 92% of the tests are ordered with other SAMSAS tests, and only about 8% order only omega-3, probably because they're ordering either other prenatal screening through NIPT testing or are choosing not to have any of the genetic tests. So we have many planned activities to try and increase our adoption and coverage from the 35% level or so to 80%, with a focus on some of the regional centres, a focus on consumers, because up to date we've focused largely on health professionals, and through our data linkage work with SA Pathology, we can actually target postcodes who are low orderers versus high orderers. I just wanted to highlight here the distribution of omega-3 status testing in ORIP. We had about 17.5% of women with low status. When we transpose that and look at the 3,000 or so samples in the implementation study through serum, again, we're getting 17% of women with low status. So this is really wonderful for us, because it shows to us that ORIP was actually representative. It wasn't just some strange randomized trial in a specific subgroup of women, and this is the population at large. And we do have about 17% of women who are testing low. Obviously, we feel it's really important for this sort of evaluation in a real life health setting to assess adoption, effectiveness. At the end, we are planning a data linkage with pregnancy outcome unit to hopefully show the effectiveness and reductions of early preterm birth in the South Australian community. Obviously, the costs will be important, and these data are all going to be important for an expanded implementation and thinking about sustainability and scalability, and what sort of business models are going to be needed in place to actually be able to pay for the program, whether it's through health insurances or other subsidisation. This sort of work is actually really important to complete, and we are feeling the pinch from some industry groups who are already marketing omega-3 testing on the internet. This is a US-based company that is selling omega-3 testing over the internet for women at the cost of about $60. They only focus on one fatty acid with a less conservative cutoff, so they can pronounce more women as depleted or deficient. And I think we need to progress our work systematically to make sure that we don't confuse the community, women and health professionals as we go forward. So with that, I would like to again say thank you to the many supporters and collaborators. A photograph here with a few other people, again highlighting the people from SA Pathology, Enzo Ranieri, who leads the maternal serum screening program, Janice Fletcher, who no longer works at SA Pathology, but was absolutely vital to get the agreement and contract in play, the partnership agreement in place, Rosalie Grivell, who has been our obstetric lead, Lucy Simmons, who has also contributed hugely through the social marketing and media. So thank you very much.
Thanks, Maria. That was wonderful and just great. So if you stop sharing, that would be great. Great to hear the story. Great to hear how you've had to embed it in the system and just the intersection between research and how you've really made such an effort to bring those stakeholders along to use usual channels, or you were told you had to use the usual channels. So you need to actually work on how you conform with the system. And then the importance of engagement with not only consumers, but GPs and the people who are actually doing the work. So look, thank you so much for that. Given that we've got about 15 minutes left, so I'm going to actually go straight to Susan to get her story as well. But please, if anyone has any particular stories, particular questions for Maria, please put them in the chat and we can follow up. And we definitely will be using this material as a showcase for HTSA to actually continue to get this message out. But that was a great presentation from start, really telling us the story. So I'd now like to hand over to Professor Susan Hillier, who, like Maria, is a very supportive colleague of the work that we're doing at HTSA, but importantly is doing some fabulous work herself and with her team. So over to you, Susan.
Thanks very much, and thanks, Maria. That's a really hard act to follow. What a mammoth series of projects. Actually, it's really great to be able to capture the complexities of what you've been doing in such a nice systematic way. So I'm presenting an aspect of some of the work that we've been doing with the MRFF rapid, can't remember the right money from HTSA. We had 2 rounds of funding for stroke data linkage work. In a slightly different way, in that the implementation work was already happening. And what we wanted to do was to evaluate how it was going, how the implementation of stroke reforms were going in the state, so that we actually could understand if it was worthwhile, really. So it's a fairly simple question, but it requires a very big team. So I'm really delighted to be presenting on behalf of the whole SA stroke community, actually. So this is in collaboration with HTSA, as you can see on this slide, and with my colleagues SA Health and all the LHNs. So if I just find my thing. What is the problem? Firstly, the bigger picture problem is that 1 in 6 Australians are going to have a stroke. And that's really conservative. There's some data coming out now that's saying it's going to be 1 in 4. And partly that's because of the relative proportion of us who are going to reach older age. It costs a lot of money, upward of $6 billion. So it's an issue from many different perspectives. And not that we want to compete with other diagnostic groups, but stroke kills more women than breast cancer and more men than prostate cancer. So we're not talking about a trivial mortality rate. And probably also equally important, from my point of view as a therapist, is that 65% of those who do survive require assistance to carry out even the most basic of activities of life. So the morbidity that occurs after stroke is equally as alarming and distressing as the mortality. So we have this double-edged issue with stroke. Now, that's the national figures. In South Australia, Adelaide has one of the highest stroke rates, and we've got one of the highest postcode stroke rates in the western suburbs of the whole of Australia. So the number of people per annum is getting towards 5,000 people per year have a stroke in South Australia. So at any given time, there's about 40,000 people living with stroke in South Australia. And this is a statistic that I just put up just to give us a bit of a heads up. This is not a disease necessarily of old age. So I choose to believe that less than 65 is very, very young. And so there's a lot of young folk living with stroke. I'm just way under 65. So, you know, let's not go there. So hopefully you'll agree that stroke in and of itself is a huge issue. It's an issue for the individuals with stroke. It's an issue for the people who care about them and care for them. It's an issue for people who are providing services at the acute end. And then it's a big issue for society and community who are providing services and care and support for those who do survive but are left with disabling conditions. So what is the particular issue that we were focusing on? Now, transforming health is probably for some people a bit of a dirty term, but for stroke, I'll just give you a spoiler alert. It's one of the best things that's happened to stroke care. My colleagues might not always agree with me, but actually I've got the data to support it. So transforming health was one of the biggest kind of health reforms ever proposed within SA Health. Not all of the reforms were carried out, but it was a very ambitious agenda occurring leading up into 2017. And in particular, stroke was quite a feature in one of the challenge areas, because there was some pretty horrendous data coming out that not only was there significant variation in practice across geographic regions in stroke, but there was really significant variation in practice depending on the time of day and even the suburb that you had your stroke in, that your chances of getting appropriate care would reduce if you had your stroke during the night, or if you had your stroke in the poles of the suburbs of the metropolitan area, and heaven help you if you had your stroke in a country area. Now, today I'm not presenting the data on the second part of our project, which was actually to look at stroke care and stroke outcomes across a period of time in rural South Australia. But I'm really happy to say that we're just finalising the analysis of that data now, so that we can really look at the changes in care and the impact of changes in care and implementation of new processes in rural stroke as well. So getting back to this current presentation, which is really looking at metropolitan reforms, what the new framework in transforming health was hoping to do was, with this broad aim of offering more equitable stroke care, particularly in the hyperacute period of immediately after stroke, And the proposal was to go from fairly ad hoc, almost 9 to 5 services, Monday to Friday in Lyle Mac. So, you could really only have a stroke in business hours if you're in the northern suburbs, to bringing something that was highly coordinated across the metropolitan area. So what this entailed was based on best practice. So there's a long-standing, decades worth of evidence, at the Cochrane level around the mortality and morbidity improvements if people receive best practice stroke unit care. And there's quite a few features within that stroke unit care that lead to improved mortality and morbidity. Some of them are things like 7-day allied health in stroke units, obviously early retrieval, team care, all these sorts of things. So what the reforms wanted was so that everybody would get access to stroke unit care, and there would be the hyperacute services available 24 hours a day centrally at the Royal Adelaide, including all the best practice neurointerventions, and that they would be very accountable 12-hour stroke intervention services in the poles, the southern and the northern, so Flinders and Lyle Mac, and that in the 8 p.m. to 8 a.m. period, anybody in those regions would be rapidly transferred to the 24-hour service. So we were also really interested to see what happened in terms of retrieval times and to see if this impact, the centralised hub and spoke model, would actually be a good thing or would actually delay hyperacute care. And this was all based on best practice, both from the stroke unit, but also from London and Manchester doing similar kinds of reforms that have been widely reported, maybe wildly reported too. So just to remind you that it was this model of the central 24-hour care at Royal Adelaide, 12-hour care at hyperacute care at Lyle Mac, and 12-hour care at Flinders Medical Centre with retrieval to the centre. This all that also then required some very careful repatriation for those 8 p.m. to 8 a.m. Folk in Callan being repatriated rapidly back to their geographical area and stroke unit so they could complete their stroke unit care somewhat closer to home. Now, to compound the transforming health initiatives, within the period that we looked at, there was a move from the old Royal Adelaide to the new Royal Adelaide, so we could also factor the impact of that change as well. So it was a busy time, 2017. So in this particular project, it's a linked data project. We had to train folk in all of the LHNs to collect data. We worked with SA Health centrally to integrate that data from the LHNs. So for some of it, we could put in place some automatic harvesting of data and real-time dashboards for some of the key indicators. But there was a much larger bespoke data set collected by colleagues across all the LHNs. And of course, as I mentioned, we also rolled this out into rural, which I'm not reporting on today. And then again, partway through the project, we got the opportunity to then link that data with a national, the OSCAR, there's a national stroke data registry set, it's a smaller data set, but then it's enabled us to benchmark against practice in other states. So therefore, the overall aim was to identify, there's a lot of data, the cohorts of interest, and that we can monitor whether we do achieve equitable access to services in a timely fashion, whether we do reduce variation of practice, and whether this does actually have an impact. Does this actually have an impact on the lives of people who have stroke? So we collected data madly, and I was asked to talk about the barriers. Busy clinicians being asked to collect data, I did not feel like Father Christmas with these asks. And I think it speaks to the calibre of people who work in stroke that, yes, I could put in research assistants thanks to the HTSA money. And yes, we could pay for someone to do the analysis, but there was an awful lot of in-kind support from fantastic stroke nurses, stroke clinicians, neurologists, allied health, who all rolled up their sleeves to collect this data day in and day out. And of course, to every stroke participant who there was an opt-out process for every stroke survivor, and very few opted out. So a big shout out to all of those who agreed for their data to be collected in this way. So we collected data on the services and processed data around every stroke admission, and we did that prior to the Transforming Health, the full implementation process, through the implementation process, and after. And this also included patient level data, so not only the service and process indicators, but the patient level data on their quality of life post-stroke, where they went after stroke, and what they received in that 3 to 6 months after. We also were particularly interested in the key interventions in the hyperacute period, because that's where retrieval, the time means brain, fits in. And we could also look at all a very key set of key performance indicators for stroke care, and we could look at those to benchmark. And we, as I mentioned, this encompassed the period from the old to the new RA, which was actually 6 months post Transforming Health. So I'm going to look at just some of this, the effect of and other changes on mortality only across the 3 metro stroke centres. But we have got a lot of other data, so I'm really happy to talk to people about another time. But basically what we did for all of the outcome data was we had a 3-month baseline period, we've got our transformational implementation period of 6 months, and then we've got a post-implementation period of 15 months of data. In this analysis, we looked at mortality using Cox proportional hazards. I'm sure that's fascinating to you. And we went up to 180 days post-admission to see, because there is this peak of mortality after stroke, but this post-stroke mortality, research tells us, pushes out into 180 days as a raised risk of mortality from the stroke. It starts to peter off after 180 days. And we did a lot of modelling, adjusting for the time periods, the hospital, demographics, and other risk factors. So, cut to the chase, what we'd find with this, there were in our period nearly 4,000 stroke admissions, the vast majority obviously ischemic. And sorry about all the data tables, but those of you who are quick reads can just see. So obviously we have different time periods, so we have different admission rates, obviously. But we could look at those time periods and see what was different and what wasn't different over the time periods. So age didn't change, gender didn't change. Now you can see that there is a slight increase in, so this is admissions to Royal Adelaide, Flinders and Lowell Mac. So during the implementation period and after, as you would expect, there are more admissions to Royal Adelaide because it does have that 24-hour service with the 12-hour repatriation. And you do see a little drop in Lowell Mac, which is interesting. And then a slight increase in, in Flinders, which is what you'd expect, and a bit of an increase in Lowell Mac, which you'd also expect, because as I said, Lowell Mac was really going from the working hours stroke unit admission to a 7-day, 12-hour admission. Severity didn't change. And then these are the 2 hyperacute interventions. So people will be aware thrombolysis is the clot busting drug administration. And it's the most pertinent to look at the percentage. That 15% rate for thrombolysis is probably best in field across Australia. South Australia has been particularly good at this for a long time. It did drop in the implementation period, and pleasingly went back up to 15%, which is, as I said, probably best in field. Across Australia, we know that from our benchmarking data. And this endovascular therapy, which is clot retrievals, this is the mechanical clot retrieval, which was also implemented around this time, went from, and this is eligibility percentages. So 2/3 of people who were eligible were getting this clot retrieval, the mechanical clot retrieval, from an intervention, a neurointerventionist. And this is probably one of the most pleasing figures, that this went up to, almost 100% of people who were eligible are now getting EVT. This was in the papers a lot around, because it's a very specialised process. There's only a few people in the state who can do it. And it's a process that has to be centralised because you need currency. People need to be doing sufficient frequency to maintain effectiveness. So it's one of these things where you can't do this service everywhere. We can't, there's no point, it's not the frequency of intervention. So again, there's a lot sitting behind these numbers, a lot of care and attention to how these things were going to be implemented, how they're staffed, how people are trained, and how we deal with that. And I'm sure some of you will remember some of the more alarming headlines about neurointerventionists. How dare they went on holidays, for example.
Sorry, Susan, I'm just aware we're just getting close. So you
nearly finished.
Take out.
Nearly finished. So this is the takeout slide. That mortality reduced. So this is the mortality adjusted death rates over the three periods. They went up in the implementation period, but overall went down. So, and this is for ischemic, hemorrhagic stayed a bit the same, but overall a drop of nearly 4. So my take-home slide is that the stroke reforms, the implementation of change of practice, is saving 4 lives for every 100 people with stroke. There was probably a slight risk during the change, so change is not without its consequences. And the other big impact is that now this collection of data is now routine. On the basis of the power of these stats, we now have funding to get these data collected routinely all the time for an ongoing monitoring of stroke care. So right people, right time, right help, equitably across all regions. Just a shout out to Lan Kelly for the analysis, Lizzie Dodd really spearheading the data collection, Tim Kleinig, and of course the MRFF and HTSA. That's it.
Wow, that's another great story. I think you can all agree that they're both stories that showed that we can actually, when bringing the research expertise and thinking and methods and everything together with a real problem, we can actually identify and show the impact that we can have. So I'm aware that it's just gone 1 o'clock, so I don't want to hold people up. I'd just like to say thank you very much to, if you want to stop sharing, Susan, that'd be great. Fabulous story from both of you. I think the message is that there are, I know we've lost a few people on the way, so sorry about that. But just to say that it's been a great journey working with both Maria and Susan, but also with many of the other projects connected to HTSA, identifying these points of what are the stories we need to tell about the success. And I'm hearing that more and more from people. These great projects are happening. How do we get the word out there to acknowledge that the bringing together of the research and health service worlds actually make a difference? So I just wanted to once again say that research impact is really important. I wanted to acknowledge 2 of my staff team, particularly Annalise, who's been pulling together this seminar series, and also Alex Mickelmore, who is our communications coordinator, who has done a lot of the behind the scenes stuff here, and also other people in my staff team. But certainly great stories to tell. We look forward to promoting these 2, our runner-up and our winner of the HTSA Impact Awards in the future. We'll be putting out a media release, so look forward to hearing from the papers and the TV, I hope, but certainly the new government. We need to be telling the people these stories, that they do make a difference, and that you guys are terrific. So thank you for your efforts. Thanks to everyone who's attended this one, and we look forward to bringing you on board for the next Spotlight series, which will be later in the year. So thanks again. Thanks, Susan. Thanks, Maria, and great working with you all. Farewell.
Thank you.